Good afternoon. So, enough has been talked about facial nerve and its relations and all kind of surgeries we have seen. So, this particular figure, I think, seen every book. As a resident, you are bound to remember this during your rounds, and also in your exam, you are expected to say these landmarks. I really want to ask our mentors who are practicing each kind of surgeries. We will go to different faculties and ask them in practical life how useful this particular figure is. What are the absolute stable surgical landmarks according to them, and which are their favorite two instruments they will keep in their hands while performing surgery. So you know what they are doing. Okay? Jan sir.
Usually the Vipul and we work together. Usually he takes a Viva. Now it is in front of us. So I think let us start with Abhay sir. Like sir, what do you believe regarding when you take invision or any incision? How do you think it is accurate?
Sometimes, as Siddharth spoke, the nerve relation is arbitrary, especially seeing the cases what he is handling. But in terms of a condylar fracture or a TJR or an approach to the temporomandibular joint per se, I would rely upon that particular figure of 0.8 to 3.5 centimeters. I would love to stay within that safety zone of not transgressing above or anteriorly to the 1 centimeter mark. So what I want to confer is that I stay within the confines of the tracheal cartilage and bear hug the tracheal cartilage and do my release. If you see when Santosh was giving the discussion on approaches, everybody spoke about the 45-degree incision given from the root of the arch, anterior superior, posterior inferior. What I would do is I have stopped doing that. I just give a 9 millimeter incision over the root of the arch and then converge it to the tragus so that I have a flap. When I do this, the nerve damage is much lesser.
So whoever has attended GYAN 2, we had on orthognathic surgery. So there was a live demonstration. So sir has demonstrated some lines. I still remember there was some.
Yes, one was the Pittengine's line and the other one is the Middleton's line. The Middleton's line, as Sid spoke, runs from the lobule of the ear to the lateral canthus. Like how you have the Ongren's lines from an oncologic perspective, I rely upon the Middleton's line from a facial nerve perspective, that I don't dissect below the confines of this line, because whatever is happening is going superiorly, being the temporal branch. So I stay much distal and much posterior.
So this is about pre-auricular incisions. Like how to say.
So sir, do you agree? Not seeing the nerve, not dissecting it, and knowing where it is actually, and avoiding that helps, right?
Absolutely.
So the conclusion would be, unless it is a parotid surgery, in every surgery we should avoid dissecting the nerve, right?
Very true.
So the reason being, there is something called vasa vasorum, vasa nervorum. Do you know what it is? Yes.
Question for audience. What is vasa nervorum?
So every nerve has also its blood supply. One great plastic surgeon has told me during my training that every problem is related to vascularity, right? So the nerve also got vascularity from different capillary plexuses, different vascular networks. There cannot be only one major artery which will be supplying the entire nerve. There will be connection. So if you dissect it, we have seen in the spinal accessory nerve, right? Even we are in the neck dissection, we are doing, we are skeletonizing it till the insertion to the origin. So that neuroplexia can happen, and it may not recover if you have also transected the cervical plexus, right?
But like every nerve has different structure. Like motor nerves are different, sensory nerves are different. So for a facial nerve, if the physically preserved, I think Dr. Siddharth would agree with me. Most of our cases we can get rid of.
So my next question is,
physical preservation of nerve is.
So if not seeing helps, then why don't we reflect the fascia over submandibular gland and retract it superiorly, and why we are going over the nerve in the fracture cases and then seeing it and dissecting it.
So that is about marginal mandibular branch you are talking
Right.
about, right? So if you are going for a neck dissection, so we would like to take that lymph node, Star's node. So that is any which way we want to go close to the nerve and we want to see the vessels and secure it inferior to that. But it is
For
when you are doing
trauma?
for a trauma
For
or any benign
pathology?
tumor if you are doing, then you might not need to take out that node.
So we will discuss this point in the next slide as well. Please remember it. My another question to Siddharth sir. Where is Siddharth sir? Yeah. So according to you, the most stable surgical landmark during doing parotids is posterior belly of digastric, right?
Not only posterior belly, the tragal pointer also.
Right.
The tragal pointer also. I told 2 point of convergence.
So
One is the posterior belly, one is the tragal pointer. Right?
So the most stable landmarks in any parotid
See,
would
I
be
don't rely on any other landmarks. The tympanomasted suture, the stylomasted foramen, the tympanomasted suture, the styloid, the tragal pointer 1 to 1.5 centimeter deep and inferior, and posterior belly. If you go above, you do not have to go up to the stylomasted foramen. Dissecting that area, the nerve will come. I believe on this still today.
okay. So if it's a redo case, suppose let's say the posterior belly was cut for the purpose of anastomosis and everything is white out, then what will you
I'm very
do?
sorry for the patient because a redo case means what? Why they will cut the posterior belly first of all by doing a parotid?
No, not for parotid. Patient
For
will be operated
purpose
for
of
some-
anastomosis,
Okay.
it is cut and
See,
the
yeah.
residual belly has retracted.
Now you have to understand. So what you have in which landmark we should rely on? I will rely on the tragal pointer,
Okay.
right? And I will use a nerve stimulator. Okay? I will never rely on the branches.
No stimulator is
Yes.
there.
So for young people, actually there are two approaches. One is antegrade and other one is a retrograde. So most of us, what we follow is antegrade. Till we do not get the main trunk of nerve, we do not go ahead. It might take some time. The patience is most important, like has already been discussed. So tragal cartilage even for me is a most stable landmark. But even if we do not get the nerve, then the theoretically described is you have to drill the middle ear, find the trunk, and then you can find the foramen.
I have to tell this. Once you are dissecting in that area, sometimes you will not get the nerve. That means you are very close to towards the mastoid. Okay, the nerve is little bit anterior when you are dissecting it. So this is the
So, sir, very quickly,
this is the mastoid. The stylomastoid foramen nerve is coming, but immediately on the mastoid the nerve is not there. Slightly forward. Remember that. Slightly dissect anteriorly, then you can see the nerve.
So it is deep situated in most of the cases. It is people try to find it superficial, but it is very deeply situated.
situated. Medially it is situated.
so how many of you have seen the onco surgery as well as trauma surgery and temporomandibular joint surgeries, everything? Okay, so I would like to ask you guys, what would be your approach for this particular patient? It's a trauma case, right? So do you agree that we are maxillofacial surgeons trained in different subspecialties, that is altogether a different thing, but we don't want to give our patient a scar, right? Or give a scar which is hidden and not visible. So why we are not giving incision in transverse cervical neck crease, and why we are putting submandibular residence and all other types of incision in a particular situation like this where we can avoid it? I just want to ask you, I am a newbie and I am a youngster. Please tell me,
Viva started.
why we are not doing it? Please tell me. What difference it would make? There is no crease here. The purpose was it will be hidden in the shadow, but in not every patient you will be able to see and perceive that this has been operated. But if you put your incision in the transverse neck crease, which is already a crease, why we are not doing it, I am asking. And I also want to come to the faculty for the same. What vital structures? See, the steps will remain same. There is skin, subcutaneous tissue and platysma. And you can reflect everything and you can do the same procedure. Patient party may accuse that you have not done surgery.
First of all, find out where is the next screen. Find out your
Yes.
person sitting opposite to, just beside you. Just see where is the crease first. Where is the position of first crease? It is little bit down.
So, if the crease is visible over the Adam's apple, you may want to go through that crease. That will give almost no scar or scar which is in the crease. So, if it is lower, then go with your regular submandibular wisdom or whatever. Right, sir?
As
So-
far as the scar is concerned, the suturing techniques have already been discussed in the morning. So, scar
So-
is not a question.
So another question, why we are not reflecting the fascia over submandibular gland and avoiding altogether, if we reflect it, that now the marginal mandibular branch will automatically get retracted along with it in superior gland, right? So why we are not doing it? We are going there, we are dissecting it, and then we are ligating arteries and whatever, and then we are fixing it. And then the neuroplexia doesn't happen. We are a good surgeon.
So he is saying there are two options: either find the nerve, marginal mandibular nerve, and then protect, or don't see the nerve. Directly go below the gland fascia and retract the whole thing. The fascia,
Fascia.
superior portion.
If the fascia over the gland is retracted superficially, then nerve will also get retracted superficially. You will not have to see, identify, and dissect.
Same way we do for preauricular. We don't need to see the branch.
So the reason being,
That's up. Yeah.
Sialosyl happens in few patients. You are opening capsule of gland, right? So that was the answer. So we are we are again coming to different faculties. What are your absolute two favorite instrument? Gunjan sir is doing every surgery, trauma, pathology, main work is head and neck cancer. So which two instrument will be in your hands in almost every surgery?
I think first thing is magnification. Then a good
Apart from magnification, in your hands while performing surgery, which are those two instruments?
I think I will have my DeBakey forceps. DeBakey forceps is must.
Sir,
I think.
If somebody calls tooth forceps, then this is about how to avoid facial nerve injury. That is why I brought it. Sorry.
Facial nerve we do not handle when you are dissecting.
Facial nerve we don't-
You
otherwise-
are not supposed to hold a nerve and dissect. It's gone.
So, he is, I think, generally is asking like for not for a parotidiectomy. Generally, which two instruments are?
You need a very good medicine dissecting scissors. You need DeBakey. You need
So-
stats.
So different faculties are using different kind of instrument.
Nerve stimulator. Yeah. Hemostats for dissection and nice scissors. Very good dissecting scissors.
Okay, so whenever we are performing any surgery near nerve, we will avoid monopolar, right? That is true. But let's say if in case we have to do neck dissection and level volume clearance, we are using monopolar, bipolar is not available. Is there any way which we can get away without injuring marginal mandibular in those cases?
We can change the setting of a bipolar. Like when you are near the branches of the nerve, you can avoid. Not for parotid. Parotid without bipolar is
And use cutting.
out of-
And use cutting in very low cutting.
For a neck dissection, suppose if the bipolar is not available, you can use with the monopolar also. You can
And
change your
And you
mode.
can use saline in the periphery to reduce the thermal injury because it has got lateral cutting. Okay, so in this particular case, what would be the best way to identify the nerve?
What I can't see.
Pleomorphic adenoma with the intact facial nerve, so
Function.
definitely nerve function. So
It is tragal pointer, posterior belly of digastric. Tragal pointer, posterior belly of digastric. Okay?
The point of convergence, you can tell that. It's not only identifying, but it is converging. There is the nerve. Okay?
Right, sir. 1 to 1.5 centimeter below.
Below.
So the treatment will be superficial paranephromy.
So if in case it is severe, you have accidentally cut the nerve, you can see those two ends. What would be the next step?
Suture is there. What else we can do?
With what suture, what magnification?
Primary neurography is a preferred procedure.
Yes.
Okay.
Suture usually 9 or 10-0.
Okay.
Nothing on under magnification.
Yes.
What would be the
Gyan, anything to take on primary neurography?
what magnification
Attended
would be
facial nerve,
required?
first facial nerve conference recently.
So any magnification more than 4.5 is good, but I am using 8x.
Okay,
The
so
higher magnification you can work with is always better. You don't have to suture them peripherally. You can take 120-degree sutures, that means triangulate, and use a glue, cyanoacrylate glue. All that you need is just coaptation.
epineural suture.
Yes, epineural sutures, just coaptation.
Okay.
Just one more thing to add, like whenever I finish my carotid surgery, I take an ampule of dexamethasone and I pour it over the nerve. And I take another care is that my drain should not be over the nerve. So there are two things to take care.
So for the last slide, we know what is to be done now because it has been already discussed. Last question would be, does steroid helps at some extent?
Yes, definitely.
Okay, so immediately you will not see, even if you have retracted and preserved, immediately on the table you may feel you have preserved the nerve. Because of edema, it will go on to second or third or fourth day. So there steroid works, right?
People doing more TMJs. Agree?
Thank you so much, ma'am, for allowing me to send you.
So when you are doing your parotid surgeries, do not tie your external jugular vein. Why? Any idea? When you are elevating a flap, right, your external jugular might cut. So what problem you will have at time? Anatomy. So much of anatomy has been taught. You have cut the external jugular vein, right? So external jugular vein is formed by what? So it will not drain there. So we have a lot of mucin in the carotid gland. Remember, this is a very, very important trick. You go on elevating the flap, you cut your external jugular, the carotid is going to bleed. Continuously it will bleed. Your field will become very tight.